Good morning, everyone. Welcome to the webinar. Today's topic is depression and older adults, and we thank you for joining us today. These complimentary webinars are brought to you through a collaboration of sponsorships through O'Connor Mortuary, Irvine Clinical Research, Care Choices, Hospice and Palliative Services, and Caring Companions at Home, along with Alzheimer's Orange County. And my name is Kim Bailey, and I'll be your host today, and I'm with Alzheimer's Orange County. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial for anyone who cares for and works with older adults. And of course, we hope that you find today's topic informative and useful. Now I want to tell you a little bit about our excellent presenter today. Her name is Allison Lyric, and she is a licensed clinical social worker and president of Cognitive Care Solutions. She brings a wealth of experience in the field of geriatric psychiatry. She spent almost 3 decades assisting seniors and their families. And here at Alzheimer's Orange County, and in fact, all around the field, we've all known her for many, many years. She holds a bachelor's degree in human services and a master's in social work. She excels at identifying the clinical aspects of senior cognitive states, as well as counseling seniors and their families to resolve emotional issues. Cognitive Care Solutions provides education to the community about brain health and services to promote a healthy lifestyle. And it's with great pleasure that I introduce you now to today's presenter, Allison Lyric.
Hi,
Allison.
So much, Kim. Hi, how are you?
Good. I'm going to turn everything over to you now. Thank you so much for being with us today.
Thank you, Kim, and thank you, Laura, and everybody that's been helping me at Alzheimer's OC. I'm delighted to be here today. Thank you. Well, today we're going to be talking about assessing depression and dementia. Next slide. So how do we do that? This is a subject that's dear to my heart. I've been working with seniors now for about 30 years, and I've seen many, many families and individuals who have, family members or themselves have depression, have dementia, or have both. And so I think it's very important to look at both and be able to possibly tease out some of the differences that we see between depression and dementia. And, which one is it? Is it that the individual has depression or dementia, or like I said, do they have both? Now, we all know that dementia and depression are extremely common in older adults. And like I said, they can appear to occur separately or both. And the diagnosis is difficult sometimes because with a patient with a dementia, sometimes it's hard to see, is it the symptoms of dementia or is it actually a depression? The problem is that if you don't diagnose the depression, that it can really affect and really be part of a decline in a person's cognitive ability, because depression, anxiety, stress are very much related to our brain health. And teasing out and treating the depression is very, very, very important. However, we don't want to just, diagnose a person with depression if they truly don't have it. We don't want to overdiagnose because, they could be put on medication that's not necessary and have another whole host of issues. So it's important to go to a clinician, a neurologist, psychiatrist, psychologist who can really diagnose and come up with a diagnosis that's appropriate for that person. How common is dementia and depression? Well, dementia increases with age. The older you get, the higher incidences of dementia that we see. If a person lives long enough, if they're lived to be there into the 80s, 90s, and certainly a centurion, 100s, the likelihood of them having some memory loss is quite likely. Now, not everybody has a dementia, is diagnosed with dementia as we get older, but it is very common. An estimated of 5.8 million Americans age 65 are living with Alzheimer's. 80% are at age 75 or older. Now, just kind of give you an idea, in Orange County alone, there is 86,000 people that have been diagnosed with Alzheimer's disease. And that number, 86,000, is probably a little bit low because that's an older statistic. We're probably looking at somewhere, gosh, high 90,000 and up. And that's only people who have been diagnosed with Alzheimer's. That's not folks who are walking around that do have some memory issues and that probably have a dementia or mild cognitive impairment who have not been diagnosed. That number also is not taking into effect the people that are experiencing some memory loss who don't have Alzheimer's disease but have one of the other type of dementias. So the number is quite high. That kind of gives you an estimate of what we're looking at in terms of numbers. Depression is very, very common in adult life. It's a little bit less common in older adults. However, as I was preparing these slides, that's a little bit skewed because of COVID now. We're seeing an increased number of people with depression now during COVID and the pandemic. So it's a little bit skewed. I would say many more older adults have depression now related to COVID and that isolation and decrease of socialization. But typically, older adults have a little bit less significant of depression. And sometimes it's because they're not being treated. They don't realize it's truly a depression. They think it's normal to have those feelings of sadness, hopelessness. But depression is not a normal state of mind for any age, whether you're a child or whether you're an adult or an older adult. Depression is a disease and it can be treated, and very, very successfully so. It also is very common to see depression with individuals who have medical issues. People who have, men especially, who have heart issues and have had heart attacks, have cardiac issues, they're at extreme high rate of depression after surgery. They become very depressed many times and also seek out treatment. More than 2 million older adults suffer from depression. So that's a pretty big number. Okay, just a little bit as far as statistics are concerned. Depression affects 20% to 27%, so roughly 1 out of 4 people have depression. Apathy, 15 to 19%, so 1 out of 6. Irritability, 15 to 19%, 1 out of 6. And psychosis, 5%, which is about 1 out of 20. So, depression, we know that's the sadness that we feel. Apathy is just not wanting to do anything, just not caring, just, just not having that get up and go. That irritability that some people have when they're depressed. Some people become more apathetic and they just don't care. Their personality just doesn't show any type of pleasure. And others become very irritable. They have a very irritable edge to them. You ask them a question and they just shout out at you and become mad for no apparent reason. We see a lot of the irritability after somebody has a stroke. I've seen many scores of patients have irritability after a stroke, and family members say to me, my mom was the sweetest person in the world. She never got cranky. She never was irritable. And now I walk in the room and she just lashes out at me. That's the stroke. That's because the part of the brain that affects the emotional filters is affected when the stroke occurs. And that irritability is just really hard to regulate. And so some people become very irritable. They just get a real cranky side to them. And then some patients get psychotic. They become so depressed that they start becoming delusional, and their thoughts are just not clear. They have all kind of thoughts that just are not real. They're not in reality. Now, the relationship between dementia and depression. There's many different hypotheses. You could open up and read many different journals, and you'll find all different types of hypotheses and people's ideas. One hypothesis suggests that depression leads to dementia, and the other suggests that dementia itself leads to depression. So you could have it going both ways. You can have somebody who has a depression and later in life they become more forgetful, and later on after that they become they're diagnosed with a dementia. Others, they have no depression in their life at all. They've had a very positive life, good relationships, good work history. Everything's been fine, have a very supportive family. And later in life, they start having memory loss, and they become diagnosed with dementia. So this could happen because the brain is damaged, and the cognitive part of the brain, the process, is in the hippocampus, and there's effect in that area of the brain. And that can become the reason that the person has the depression, and that the reason it leads to dementia as well. But I see a lot of patients who have, when when they have dementia, they also have depression. And it's, for many people, it goes hand in hand, because having the diagnosis of a dementia is very debilitating and very sad. And it's difficult because, at this point in time, unfortunately, we don't have a cure and we don't have prevention. So people feel out of sorts and are very discouraged by it. And that's one of the most important things to do, is to reach out and surround yourself with activities and different things that you can do to help keep your brain stronger. So people that have depression, it is a treatable disease. There's many different treatments for it, which we'll talk about in a few minutes. Now, according to what's called the DSM-4, and that's sort of, I'll say, quote unquote, the Bible for diagnosing, for mental health. That's everything. It's a book that's about this thick, I think, and that's our go-to book for diagnosis. So we just can't say a person is depressed, or a person has dementia, or a person has anxiety. There's different criteria for each disease, and you have to fall within that criteria in order to have that diagnosis. And that gives us the foundation so we can treat a patient with those types of diseases. So for depression, we have to have 5 of these symptoms that last for at least 2 weeks. So one of them is depressed mood. That's the feelings of sadness and crying, things of that nature. Anhedonia is a fancy word for a person who doesn't have any pleasure. They don't see pleasure in anything that they do. Even though they might have always loved to get together with their grandkids every, holiday, special occasions, and during the week, they just don't find that to be pleasurable anymore. They just want to stay in bed. They have no get up and go. So that's a good example of somebody who has anhedonia. Changes in sleep. Some people who are depressed sleep too much. They don't have any purpose. They don't have a schedule. And they just figure, well, it doesn't matter if I get up at 8 o'clock in the morning or 12 o'clock in the morning. Who cares? What do I have to do? So they just, they sleep too much. Others have insomnia versus the hyperinsomnia. And insomnia, you don't sleep. You lie in bed and you count the speckles in your ceiling. And that's a tough place to be in. Neither are good. Obviously, sleeping too much has its own issues, and sleeping not enough has other sets of issues. Sleep is extremely important when treating depression and looking at brain health. We have to get our sleep regulated. And I hear this all the time. I think it's like it could be like a wise tale now, is that as you get older, you don't sleep. And I know many doctors kind of brush that under the table and say, well, I've heard it directed towards me. Allison, your patient is 90 plus years old. Of course they don't sleep. And I fire back and say, well, that's not okay. They have to be able to sleep. Sleeping can really affect the whole day and the whole week and the whole month. And sleeping is extremely important for their brain health. So we want to be able to sleep somewhere between 7 to 8 hours per night. It doesn't need to be straight 7 or 8 hours. If you have to get up to go to the bathroom a couple times and you go back to sleep, that's okay. But we want to be able to have 6 or 7, 8 hours of sleep. Appetite changes. That's another criteria for depression. When somebody starts to not have appetite, then that's not good. They start losing weight, and that's not healthy. Or they're eating too much. They're eating a lot of junk food. That's not good either. Fatigue. We want to be careful with fatigue. Patients just don't have, again, that get up and go. They're just tired. I just took a nap, but I'm still tired. They don't have any energy. Agitation. They feel agitated. They're antsy. They can't sit and focus. They're jumping up and down. They just feel like they want to crawl out of their skin. Feelings of worthlessness. I'm not worth it. I'm a bad person. I'm too, I'm too heavy. I'm too this, I'm too that. They don't have any feelings of positive. They don't have positive feelings. Everything is worthlessness. You have to have impaired concentration. They're the folks that say, I used to be able to multitask and now I can't. I can't even do one thing without forgetting. When you're depressed, you can't think as well as you once did, and your concentration decreases. So having that treated, identifying that is obviously very important. Thoughts of death and suicidal thoughts, thinking life isn't worth living anymore. Now, we have to be very careful with this because, obviously this is very dangerous, and we have to assess when there's a plan and then when there's attempt to do something. When there's a plan and they know what they want to do. That's the most seriousness. Sometimes people have thoughts of death. What is it going to be like? And they get scared. Or life isn't worth living anymore. Those types of things. But when you ask them, do you have a plan and do you have intent? They say no. But they have those thoughts. So assessing for suicide is extremely important. So like I said, in order to diagnose a person with depression, they have to meet 5 or more of these symptoms for at least 2 weeks. If you have these symptoms and it's for less than 2 weeks, then you truly aren't depressed. You don't carry that diagnosis of depression. You might have depressed mood, you might have some anxiety, but it's not a full criteria. It doesn't meet the full criteria for depression. Now, depression in older adults sometimes looks a little bit different than with younger people. Generally speaking, older adults become a little bit more irritable. I hear the family say, mom or dad is very cranky. That's not like them. They just complain about everything. They're grouchy. They have an irritable edge. They have low energy. Everything is difficult. Everything is hard to do because they just don't have that get up and go. They're just tired. They sit in a chair and they don't do activities. And that's one of the worst things that you can do for depression and for brain health as well. Many older adults suffer from insomnia. You just can't sleep. You lie in bed and what happens? You stare at the ceiling and things just get worse. You start laying in bed and then you start worrying about different things that you have no control over. And you start thinking about your kids, your grandkids, financial concerns, everything. And at the end of the evening or the end of the night, you realize I haven't slept and you're nervous and you're anxious now. So now you have more of an anxious type of depression. Changes of appetite, many times it's a decrease. Patients don't eat as well. And a lot of times it's simply because they don't have, again, that energy to do the cooking. It's hard to cook for one person and have that portion control. It's much easier, A, not to eat or start eating things out of a box that aren't maybe very healthy. And so your changes in appetite is a big concern. Anxiety, like I said before, is also an issue, feeling nervous about things that you can't control. Somatic complaints, complaining of bodily aches and pains that maybe you never had. You're real focused on that knee pain that you've had for the last 6 years, but now it's even worse. And then cognitive changes in your memory, not being able to do things and multitask like you once did, being concerned that you're not remembering different appointments, being concerned that you can't remember people's names as well as you once did. So we do see changes in cognitive in the cognitive arena with depression as well. And many times when you treat depression, guess what happens? Your cognitive abilities improve. And so folks who had some complaints of, memory, after we treat them for depression, then we see an increase in cognitive ability. Okay, a client with dementia is a little bit different than that patient who has depression. Now, the general response to cognitive and functional decline is that this is it's a frequent concern, and a lot of times patients who have these changes deny it. They'll say, if I ask them, Joe, do you have any changes in your memory, or do you notice that you're forgetting things? And many times they'll say, oh no, my memory is fine. And then 3 minutes later, they'll ask me the same question again. Either A, they don't realize it, or B, they forget that they have forgotten. And so they don't have that ability to talk and to process like somebody who just had that depression. Their mood many times is labile, which means it's up and down. Sometimes they're very happy, and other times, like I said before, they're very irritable. I've had patients who families have told me that they have been, like I said before, the nicest person in the world. I've had daughters tell me, my mom has never said a bad word in her whole life, and now she's cursing. Now she's using bad language. And many times we see that with patients who have either vascular dementia or a frontal lobe dementia, because that part of the brain is what's affected. And so again, their mood is very labile. 1 minute they're happy, and the next minute they're very labile and maybe shouting. Again, interest, it's a gradual loss of interest. They become very apathetic. They just don't care. Eating. Generally speaking, I see both a gradual loss of weight and also a lack of eating. Sometimes I see patients who eat a lot of sugar, a lot of treats, cookies, cakes. They don't eat a lot of good food and nutritious food, but the food they do eat is, basically quote unquote junk food. They're sleeping. They do have usually a sleep-wake cycle disturbance. And sometimes people with dementia do have what we call psychomotor agitation, that inability to sit still, and they become very antsy. Now, a client with dementia, again, with the energy, is poor initiation. They don't always initiate things. They're happy with doing what they're doing. A lot of times it just could be sitting in a chair and staring at the ceiling, staring at the TV. They make transient statements about their own decline. And sometimes they feel very worthless and they feel guilty. I wish I didn't have this. This is a huge effect on my family. Concentration and their thinking also is decline, and that's part of the disease process. And suicidal thoughts, a little bit more common and important to assess because they're feeling very hopeless and hopeless. They're seeing what the disease has, the effect the disease has on their family and friends, and they're feeling guilty from it and also very sad. Now, some risk factors of dementia, like I said before, there's a lot of different studies out there. Pretty much the research does show that depression is definitely a risk factor for dementia. And if a person has a depression, we tend to see a more rapid decline of their thinking and their memory skills. Treating depression can lower the risk of dementia. And the important thing to take away from this talk is that dementia is a treatable disease. Depression is a treatable disease. Whereas dementia, we don't have as much that we can do for it. We have some things that we can do, but we certainly have more treatment that we can do for depression. We can treat the anxiety. We can help get somebody on more of a sleep-wake cycle. Sedentary lifestyle, we can help somebody become more active. We can improve their nutrition, and we can also increase the socialization. So, we do this by treating the anxiety. You can see a therapist for talk therapy to treat depression and the anxiety. We can look at oftentimes sleep. And sometimes sleep is a little bit tricky because we can do things like look at, do you take naps during the day? And is that why you're not sleeping? Are you eating foods at nighttime that might have a effect on sleep? Such as, eating or drinking caffeine. Are you drinking tea or coffee? Are you drinking chocolate, extra sugar? Becoming more active. Now, during COVID, it's a little bit tougher to become more active outside of your house. But there's so many different things that you can do to increase your lifestyle, and different things that you can do to become more active and increase socialization. And nutrition too. Sometimes it's just a matter of buying things maybe that are prepared but are healthier. Okay, just real quick, there was a couple of studies over at the Rush Alzheimer's Disease Center in Chicago, and they found that treating depression can reduce the risk of dementia in older adults. And they studied about 1,700 people that were about the average age of 77 years old. And these folks did not have any memory issues at all in the beginning of the study. And they watched these, they screened these folks for about 8 years, and they looked for the symptoms of depression, including their lack of appetite, loneliness, and they were given memory tests. And they found that a total of about 315 people had developed, which is about 18% of their study, a dementia. And 680 people, unfortunately, they passed away during this study. And they found that when they did autopsies of their brain, that they did have markers for Alzheimer's disease. They did have those plaques and tangles. So they did find a relationship between depression and dementia. Okay, so let's talk a little bit about some case studies, and let me give you an example so we have a clear understanding and what these folks look like. Mr. Keith Smith is a 72-year-old male. He had a very successful career in mortgage banking and was employed as a CEO. Mr. Keith noticed he was having difficulties with his short-term memory. His friends/colleagues were noticing that he was forgetting appointments even with his golf games. He knew something wasn't right with his brain, but continued to deny any problems. His friends began to razz him about his short-term memory, and he also was saying things to his friends in a less caring manner. His wife became concerned and scheduled an appointment with a neurologist. So this is a patient who probably didn't have any baseline depression. He was a CEO, like I said, very active, had a full life, very supportive family, and he began to have problems with symptoms of memory loss, and he denied it. And when he finally went to the doctor, unfortunately, the diagnosis was mild cognitive impairment, so the beginning stages of, some memory loss and moving towards dementia, mild cognitive impairment, moving towards mild dementia. And after receiving the diagnosis, after going through the testing and getting diagnosed, he became extremely depressed. So much so that he cut off seeing his family and friends. His family was extremely supportive. He had a lot of grandchildren that loved him and really admired him. And he decided that he just couldn't see them anymore. He was embarrassed. He didn't want the grandkids to see him the way he was and to notice that he had some memory impairment. So he told his wife that he just wanted to stay in the house and not see anybody. And he became extremely isolative. And this is all way before COVID. This had nothing to do with COVID. And he became extremely isolative, no socialization whatsoever. He watched TV throughout the day, didn't engage with anybody. And about a year later, he had sought some treatment. And during that time, he not only did he become more depressed, but his cognitive skills really plummeted, and he became much more confused and forgetful. And until he sought treatment and the depression was treated, he was on a pretty bad course of the disease process. But he did receive treatment for the depression and really improved quite nicely, along with his short-term memory. So he was a good success story. Next case study. Okay, how is depression treated? So we want to look at, is it depression, is it dementia? And like I said, dementia will unfortunately get worse over time. So we want to be able to treat any type of dementia so that we can try to stave off the progression of dementia. We want to treat the depression, and try to stave off the dementia. Now, some options for treatment is definitely counseling. A method of counseling that is very effective is cognitive behavioral therapy. It's called CBT. And that's looking at false beliefs that we think, thinking to yourself, oh, everything's all bad, I'm worthless, and changing those kind of things around that are more positive. Um, Medication management. Sometimes we need a little bit of medication to treat the depression. And even more, sometimes medication and therapy will really help improve that depression and help a patient bounce back to their baseline or pretty close to it. We also want to look and try to understand the cause of it. What is the depression coming from? Where is it coming from? Is it biological as well as psychosocial? Are there any type of medical issues going on that are affecting the treatment of depression? And treatment is unique for that individual. Some people respond just to therapy alone, and some people respond better to a combination of medication and therapy. And nothing's permanent, you know. Um, Sometimes being treated for depression, can be a year and a half, 2 years, and then you return, to your baseline, and things are good again. And at that point in time, then we can tease out, is it just depression, or is it a combination of both depression and dementia? So in between that time frame, we're looking at the possible reasons and the baseline for the cause of depression. Okay, now we also want to look at the individual's home and environment. Are they safe at home? Do they have everything they need? Are they getting enough food? Is their house clean? Things like that, environmental. We want to minimize changes. When a person is depressed, that's not the time to start making a bunch of changes in their life. Keep everything sort of status quo. Have a predictable routine. We don't want to stir things up, but we also do want a routine. We want to make sure that we have a reason to get up in the morning. You need some type of something to look forward to. Of course, we want to minimize any type of stress and anxiety. A quiet environment that's not full of chaos. Exercise and sleep is two very, very important things that we want to look at and try to increase. And we want to do pleasurable activities. We want to do things that we enjoy. Now, again, we want to try to increase social interaction, which I know is hard during COVID times, but we have to look at possibly ulterior things, doing meetings on Zoom or FaceTime, maybe meeting in very, very, very small groups. I'm kind of for the Zoom meetings, but some I know like to go out and spend very small groups, 1 to 2 people. And we can sit and debate that, but um, obviously wearing a mask and social distancing is extremely important if you choose that. But just in general, the social interaction is really important. And then relaxation. If you're feeling anxious, to relax and maybe try meditation of some sort. Okay, so it's common with clients who have dementia is that they deny any type of depression. Sometimes they have a limited insight to their disease process. They have a lack of awareness, and sometimes they even become argumentative. Now, this is a case study about Mr. Jones, who's 76 years old, retired engineer. He holds 2 PhDs. One is in bioengineering and the other in education. He was forced to retire about a year ago when he was having some short-term memory issues. He accepted the need to retire well and was looking forward to resting. During the last year, he has spent most of the day in front of the television. He does not have any desire to engage in reading or doing any type of brain exercises. When asked about his daily routine, he smiles and says, "It's a wonderful life." And my question is, does he have some depression? This is a guy who has 2 PhDs, very smart, very intelligent, was a bioengineering major. And his lack of wanting to do things and stay in a daily routine kind of gives me the hint that he does have some depression, as well as the dementia could be limiting his ability to make good decisions. And again, it's that limited awareness, not really understanding the disease process, like I mentioned before, not having that get up and go, just feeling like, okay, life is fine and I'm just going to sit and rest. It's not the same as a person who retires because they want to do traveling and they want to do all the things that they didn't do during their lifetime. And now that they're retired, they're going to be busy with traveling, being on maybe different, boards, become a board member, um, doing things that they didn't have time to do during their life and want to do it now during retirement. That's different than what I'm talking about. He doesn't have the oomph to do things. He doesn't see the importance of keeping his brain active, exercising, getting good sleep, all those kind of things. So I think he has some depression, and he definitely has some issues with memory. Next slide. Oh, the patient is a 72-year-old female who has heart disease, cardiovascular disease. After a heart procedure, she started to notice some minimal changes in her memory. She was unable to focus and multitask like before the procedure. She was also having some difficulties remembering people's names and appointments. She does have a history of depression, which she was being treated for. The more she noticed herself forgetting, the more she became anxious. The doctor recommended that she slow down and retire. And what happened next? This is a little bit on the tricky side because this is a person, again, who was pretty high functioning and had the heart surgery, had the cardiovascular surgery, and then started to have some problems with their memory, which is very common after heart procedures because of oxygen and also because of anesthesia. So I'm not on the same course of treatment as slowing down and retiring unless she was doing too much. I say that she has to kind of switch gears and still have things that are important to her, still keep a daily schedule. When people are feeling depressed, we want to make sure that they have a schedule and they have a purpose in life. They have to have things to look forward to. Otherwise, a person like her is going to have a difficult time because if they slow down too much, they're not going to have that purpose. And then their retirement is going to become just a time in their life where it doesn't matter whether they're going to get up at 8 o'clock or get up at 12 o'clock. And so that purpose and that schedule, those priorities are extremely important to have. But she does have some depression, and especially, the key is that she had it prior to the heart surgery. And I think the heart surgery just confounded it again because probably maybe some inactivity and also because of the anesthesia and loss of oxygen. Okay, last one real quick is Mr. Baker is an 85-year-old male who was diagnosed with frontal lobe dementia. He is a retired computer programmer and holds a PhD from Harvard. He once had his own company and was a professor at Yale. He was diagnosed with frontal lobe dementia about a year ago. During the assessment, he denied any signs of depression. When speaking about his daily routine, he stated that he enjoyed sitting and watching TV throughout the day. He didn't have much interest in his family, even though he had 5 grandchildren and 2 great-grandchildren. What's next? Now, this is a good example of a gentleman who has a dementia, who doesn't understand that keeping his brain active through doing, exercising and good nutrition and brain exercises and getting good sleep and interacting with his family and friends and also his grandchildren is vital. This is a guy who is very intelligent, like the other gentleman that we talked about, who normally would not have been just sitting around watching TV. I'm sure he would have been investigating and looking at research information and articles, looking at how he could improve his brain health and what he could do for the dementia. But instead, because of the lack of awareness, he's chosen not to do those things and just to be apathetic. So for him, it's a combination of the dementia and probably also some depression. Okay, thank you so much
All
for it.
right.
If anybody has any questions, I'll leave it to
I
you.
didn't mean to interrupt you, Allison.
No, I wasn't sure if you were gonna.
I'm here. Thank you so much, Allison. That was really fabulous. And we do have a number of questions from our attendees.
Great.
So before I get into the Q&A, I just want to thank our sponsors once again, O'Connor Mortuary, Dr. Trin and Irvine Clinical Research, Care Choices Hospice and Palliative Services, Caring Companions at Home, and of course, Alzheimer's Orange County. Let's see, let me open up the question box. and see what we have for you. Bear with me here. I just want to take these in the order that they came in. Okay. Agitation sounds a lot like anxiety. Anxiety has been shown to have relationship with depression. Is anxiety related to depression?
Definitely. Anxiety can be a part of that depression. A person can have more of an anxious type of depression where they can't focus, they're feeling nervous, versus a person who just feels more apathetic. They just don't have that energy. So they can feel nervous or they can just be more on the flat side.
Good. Thank you, Allison. And let's see, the next comment and question. My chiropractic female patients are eating more and the male patients are drinking more. I think this relates to COVID. Or maybe just in general. Sometimes even if they're pre-diabetic or actually diabetic, their MDs never ask and the patients do not say anything because they know it's wrong. This is worse with COVID lockdown and less outside activities, especially if they live alone. So are there online groups for seniors? So again, she's talking about, some behavioral issues that are going on with some of her patients, her chiropractic patients that their MDs are overlooking, and she's wondering if there's some online groups that she can refer them to, or other resources perhaps.
So is she looking for, I'm not quite sure on the question. There's lots of different support groups available. But for caregivers, for Alzheimer OC has many different support groups that you can refer to for caregivers, for individuals who have been diagnosed with MCI.
Yeah, she doesn't say whether their Alzheimer's is part of the equation here. I think she's just talking about depression here because she's saying she's seen behavioral changes in her chiropractic patients. She's seen people drinking more and eating more during COVID, and so maybe mental health issues.
Right. So I'm always concerned when patients tell me that they're depressed and then down the road they tell me that they're drinking as well. Whether it's, a glass of wine, there's research that shows that red wine, especially red wine, is, good for you because of the, grapeseed and all that, resveratrol. Other studies show that it's not. So that's a debatable issue right there. But from a clinical standpoint, I'm concerned when people tell me that they're depressed and they drink because drinking alcohol is a depressant. So here I'm seeing a patient for depression, trying to treat that depression, and we're trying to raise them up, right? We're trying to decrease the depression, make them better, and then their alcohol is pressing them down, so to speak. So we're like this, and then if they're taking medications, antidepressants prescribed by a physician, you got a cocktail going on that's, you're not going to have your optimum is not there. So the drinking I'm always concerned about if that's what you're talking about. But certainly, through the Mental Health Association, there's support groups. But if you have specific questions, the next slide when we finish the questions has my contact information, and you're more than welcome to contact me, and I'd be happy to talk with you more about that particular question.
Yeah, there's the slide that gives your contact information. I think that's great. Any of our viewers, if you have questions of that nature or want more information about Allison's service and what she offers, please feel free to reach out to her. That last question made me sad because, thinking about older adults who are living alone and so isolated even before COVID, and now after COVID, talking about these behaviors, thinking about what they're saying and what they're not saying, we know there's a lot beneath the surface there. And so my heart goes out to people having these issues, and I hope they can find help.
Definitely.
Thank you for raising that issue. Okay, here is a question. I have a client who has all these symptoms. I assume the symptoms of depression, plus rapid heart rate at times with noodle-like feelings in the body, but no medical condition. Can this be part of depression? Noodle-like feelings.
I'm not quite sure what noodle-like feelings means. If you're saying like they feel like they're limp, I mean, that sounds like they're kind of apathetic and they don't have that energy. They're fatigued. Um, I would just make sure. I think you said, but I would make sure that they go to their physician, their MD, internist, um, particularly a geriatric, internist, and really have a good medical workup. And I should have said this in the beginning, is that first things first is to have a good medical workup to make sure that you're
Right.
not either on the depression side or the dementia side, is that you're not missing out on some type of vitamin, or there's not something medically going on that's causing these kind of feelings. I'm just thinking that anxiety, as women that are going through menopause, anxiety is a huge symptom of menopause, and so is depression. And so if you know that these are the symptoms, then it takes the scare out of it, because you know that I don't want to say it's normal, but it's common, right?
Right.
So it's important to go to the doctor, that's somebody that you trust, and make sure that there's nothing medically going on.
Great. Thank you, Allison. Okay. Has anything related to the depression diagnosis changed on the DSM-5?
I don't think so.
Yeah.
I think
how
it's
often
been,
is that? How often are updates published? Annually or?
gosh, no, it's not annually.
Okay.
I'm not, I don't think it's been updated for at least a couple of years.
Okay. I said DSM-3. That shows
Right,
you how out
exactly.
of
Well,
date I
we're
am.
both going back, right? And I heard you, and I thought, I kind of chuckled too, because I remember those. I remember DSM-3. I'm trying to think when the 5 was updated. It's years now, I believe. I look everything up on the computer because of the ICD codes I have to bill. So that's kind of my cheat sheet. But I don't think
Okay.
anything's changed majorly with depression. We've had some
Okay.
changes like in dementias and stuff.
Okay. Okay, and this is a point of clarification, and I'm not sure which slide we were on, Allison, but there was a reference where it said suicidal thought. You said suicidal thoughts are more common, but the slide said suicidal thoughts were more uncommon. So which is it?
It's common with depression. So
Okay,
suicidal thoughts doesn't mean, so when you talk about suicide, we're talking about thoughts, we're talking about intent, and we're talking about a plan. So people can say, I just want to die. But when you ask them, do you have a plan? Do you know how you're going to do it? Would you take pills? Would you hang yourselves? Would you, poison yourself? And they say, oh no. Or you say, and do you have intent to do it? So they can have the desire, they can have the feeling, and they can have a plan. But when you say, would you do it? Hopefully they're going to say no, because it's against my religion, or I couldn't do it to my spouse or my kids.
okay,
But it's
okay,
very important to always disseminate whether or not it is a lethal issue.
okay. So there's a huge difference between a patient saying, I think about dying, or I think about killing myself, as opposed to I have a plan for it.
Exactly. And and
Okay,
and that and then also the next step is their intent. I mean, the
right,
intent is really that's going to tell you, is it going to happen? If somebody tells me they have the thought, but they don't have a plan and they don't have intent, I take it
Or
seriously.
means.
And the means, right? But
Right.
if they tell me that they have, if I have a patient who tells me and they're methodical about every step of the way, well, then I've got to be, right there with them, and I have to get them some help immediately.
Okay. You have to report it.
Absolutely.
Okay. Gotcha. I hope that answers that question. Okay. Now let me go to the next question. If a person is diagnosed with dementia and then develops depression, are there medications for depression that they should not take because of the dementia?
That's really a question that, medication, I'm not a physician, so I think medication questions like that, I'm going to refer you back to your neurologist, PCP, psychiatrist.
Okay. The next question is, can a patient with dementia benefit from therapeutic counseling, or would the therapy be only medications?
It depends on where they are in the dementia journey. My company, we specialize in treating patients who have mild cognitive impairment and mild dementia. And so we provide therapy for those patients that have either or. But as a patient travels more into the journey and has more dementia, more confused, then different types of treatment is more beneficial. The talk therapy won't be as beneficial in later stages of dementia.
Okay. Thank you. And let me see what else we have. What is a range of how long it might take to treat someone's depression?
Ooh, that's a hard question to answer. It all depends, in my opinion, it all depends on, a big part of it, I should say, depends on their motivation. I treat patients who are very motivated. Just the mere fact that I let them know that depression is treatable and that there are things that we can do to treat their depression is so motivating that they can't wait to get their arms around it and do what they have to do. And
Right,
then the spectrum, so the spectrum's like this. There's people that are,
right,
very, very motivated, down to I'm only here because, my wife tells me I should be here, type of thing.
yeah,
But there's other variables. There's biological variables as well. So
right.
it's hard. But I would say, as far as treatment of depression, probably anywhere from 6 to 9 months to, a year and a half. I think it's kind of an average. And it depends, if you're doing just therapy alone, if you need some medication, if it's a combination of meds to kind of give a jump start, that sometimes is helpful as well. But the,
Okay,
the
okay.
the big take home is that it's treatable and there's things that you can do.
Good, good. We have more questions, but I want to pause for a moment because we have been online for 60 minutes. And in the event that some of you need to leave, I encourage you to stay because we'll probably be finished in about 10 minutes. But if you do have to leave, I just want to mention a couple of things. One is that we hope you'll come back next month for another free webinar, and our topic will be Parkinson's disease and its effect on cognition. And our speaker will be Donna Sperlakis, and she's the Director of Community Engagement at the Parkinson's Foundation. So that'll be a really fascinating topic. And then again, we need you to fill out your survey. If you leave before we end the webinar, you'll receive that over email, and you have to complete that within 24 hours. So let me go back to the questions real quickly. And it looks like it's on that kind of similar topic of range of timing. In the area of total denial of symptoms, how do you even approach a person regarding visiting a physician to start the diagnostic process? And I'm not sure if they're talking, I assume they're talking about depression here, not dementia. But if someone's in total denial, how do you approach them about getting a diagnosis
I think
of
it's baby
depression?
steps. I think
Mm-hmm,
it's do they have a good relationship with their physician?
mm-hmm,
If the answer is no, then it's going to be harder. If they have a really good relationship, then it might be a matter of saying, sometimes you have to say little white lies. Doctor so and so's office called, and they see that they haven't seen you for a while, and they want to do a visit with you, and we can do it through telehealth. Telehealth now has become very it's easier for a lot of folks because it takes the driving and all the getting ready and all that away. So a lot of people have been more amenable for getting help simply by using telehealth services. So now that that might help.
Right.
But being meeting the person at where they're at. What is it about the going to the doctor that's scary for them? Is it because they feel like do they really truly think that there is a problem, and going to the doctor is going to put the light on that problem? So meeting the person, and discussing those kind of things with them. And sometimes, quite frankly, little white lies have to occur to kind of get over a hump. But I think baby steps is what's important.
Right. Thank you, Allison. If someone who is 85, just got diagnosed with depression and put on medication, should they be seeing a therapist?
It depends on. It doesn't hurt. I think it's helpful because medication has its piece from a biological standpoint and the brain. And then, I'll go back to COVID, especially now, people are so much more depressed and isolative, and they lack social engagement. And so talking to somebody, one to one, can be so good for them. And having that hour that they know that is unconditional, that person's not going to have any judgment, any expectations, so to speak, and just there for them. So, from what I do, I'm going to say yes, because I think it's important. Who doesn't want somebody to listen to them with
Yeah,
no judgment?
that's a great answer. Thank you. Um, are there over-the-counter supplements that can be taken as a way to help avoid these issues?
Again, I'm gonna punt that over to talking with a doctor, or I mean, the answer is yes. There's a lot of different herbal supplements that you can take, and things like that. But I'm gonna punt it to going back to the doctor and talking to them. And the one thing you have to remember is that traditionally MDs are not trained to talk about supplements. They're medication focused. So if you really want to, I tell patients, if you really want to focus on more of the supplements and that kind of stuff, you can see an MD, and you can also see more of an integrative type of doctor, maybe a chiropractor, an MD who also is trained in integrative, health, things like that, more knowledgeable about, more supplements. You can have a combination.
Or would a nutritionist be, I mean, wouldn't some of the things you need be available naturally through the right
Food,
foods,
sure,
eating the right
sure,
diet?
hmm
Okay.
sure.
Okay. What is the difference between apathy and anhedonia? Did I say that right? You mentioned that term.
Anhedonia. It's
Okay.
very similar. It's that lack of pleasure.
Okay.
Lack of
Lack
pleasure.
of pleasure. Okay. I learned
It's a
something
Greek.
new today.
It's a Greek word.
Yeah. Great. There's also many comments just stating how much they enjoyed the presentation and you.
Oh,
So,
thank you.
and you'll
Thank you.
get a lot of those on the survey as well. What
Thank you.
treatment modality do you recommend using with clients?
In my 30 years of working with people, I'm kind of one to use more of a, um, I would say, especially now with patients who have MCI and mild dementia, more cognitive
Hmm.
behavioral therapy, CBT definitely. But I can't, it's very hard for me to look at seeing people and treating from a CBT model because I was trained more systems, family systems.
Hmm.
So I also look at where the patient is, where the individual is in terms of their system, what their family looks like. Because I think that, especially being an older adult, that plays a big part of it. Is there a connection between, family? Are the loved ones available to help? And so I look at things from also from a family systems perspective, as well as some CBT.
Okay, and actually, Allison, I cut off part of that question. She was asking, what treatment modality do you use in light of the fact that, you know, your clients may have dementia and their insight is not that effective, you know, or renders other treatment modalities ineffective. So I think
Right.
your
So,
answer still holds.
right. See, I would definitely CBT and definitely the family systems, and really being where I think what's really important is meeting the patient where they're at that day. You know,
Right,
when I'm,
right,
it reminds me of when I'm training or talking with new therapists, and collaborating with therapists, bringing them on to our program, and they want to know, what's kind of the cookie recipe, the cookie cutter
right.
recipe, and there isn't one because it's therapy.
That's
And
right.
I'll say the best thing I can tell you is meeting the client where they're at, because if you have an agenda, if we're going to think, if the client comes in and I'm thinking that we're going to do more brain exercises that day, and yet the patient's coming in because they got in a big argument with their spouse, why am I going to sit there doing brain exercises with them? We have to get into the meat and potatoes of what the argument was, with their spouse. So meeting them, I think really when you're working with folks who have impairment, meeting them where they're at is crucial. That's
Right.
that's what I would say.
And with that, on that note, I think we're going to have to wrap up because we've gone 10 minutes over.
Yep.
If for some reason we did not get to your question, Allison has given us permission to, you can reach out to her with your question, or you can call our helpline. Our helpline is always available to answer your questions. It's been a great presentation, Allison. We thank you so much. Very informative. And thank you so much for being with us today. And thanks to all of the attendees for hanging in. We still have a lot of people on the line that stayed over for you. We thank you for attending. And again, next month, we'll have another great webinar. We'll have someone talking about Parkinson's and its effect on cognition. Thank you once again to our wonderful sponsors. We couldn't do this without you. O'Connor Mortuary, Irvine Clinical Research, Care Choices, Hospice and Palliative Services, and Caring Companions at Home. So this is Kim Bailey with Alzheimer's Orange County signing off and wishing all of you a very pleasant afternoon.
Thank you.
Don't forget to do your evaluation. It should be popping up just as soon as I end the webinar for everyone. Thank you so much. Bye-bye.